All right, welcome to the deep dive. Today, we're going deep, really deep, into something that, well, we all do every single night, sleep. But more specifically, how we breathe when we're asleep.
Yeah, it's more important than you might think at first glance, right?
Oh, absolutely. We're going to unpack a whole bunch of stuff. Obstructive sleep apnea, hypopnoea syndrome, you might know it as OSAS.
Process, yeah.
Obesity hypoventilation syndrome, OHS.
OHS, yeah.
And then there's this whole other thing, the COPD-OSAS overlap syndrome.
That's a mouthful.
It is, it is. And what I think is really cool about this deep dive is that we're going right to the source, a nice guideline published back in August 2021.
Yeah, nice guidelines are pretty much the gold standard, so we're talking evidence-based stuff here.
Yeah.
And I think what's great for everyone listening is whether you're, dealing with this yourself, maybe someone you care about is, or even if you're a healthcare pro just wanting to brush up.
Right.
Our goal really is to break it all down, make it clear what's the must-know info, and hopefully point out some of those surprising connections that, you might not expect.
Yeah, exactly. So our mission, if you will, today is to give you a solid understanding of these sleep-related breathing disorders. What are the red flags? How do you actually get it diagnosed? And then what are the main ways these are treated in adults, 16 and over?
Think of it as like your cheat sheet to being in the know without having to wade through a ton of jargon.
Exactly, exactly. Now, before we jump into all the details, we've got to get a really important safety announcement out of the way.
Right, so to cover the bases.
Back in June 2021, the MHRA, they issued a safety alert about some Philips ventilators, CPAP machines, and BiPAP devices. So this applies to any of those machines that were made before April 26, 2021.
Okay, older models.
Older models, yeah. It's because of potential risks from particles and these volatile organic compounds, stuff that could be inhaled.
Right, so basically potential irritants or in some cases even harmful substances getting into your lungs when you're using the machine. Not good.
Yeah. So as we're talking about CPAP and BiPAP, keep this in mind. This alert is super relevant to everything we're talking about.
Absolutely. Safety first, always.
Right.
All right, are we ready to tackle OSAS?
Let's do it. So, OSAS, obstructive sleep apnoea. Imagine your airway. It's the pathway air takes to get to your lungs.
Simple enough.
When you fall asleep, all your muscles, they naturally relax. Makes sense. But for some people, this relaxation makes the upper airway narrower.
Okay.
Or even closes it off completely.
Oh, wow.
Yeah. And this narrowing leads to, well, not enough breathing. We call it hypopnoea. Or even complete stops in breathing, which is the apnea part.
Your body's literally like, hold on. Got to get some air in here.
Exactly. And it won't just let you stop breathing. You'll either wake up briefly or your sleep gets lighter, and it's all so you can start breathing again.
It's like this little mini restart happening all night.
It is. It is. But this cycle, it can happen so many times, dozens, even hundreds of times throughout the night. And that's when you get sleep that just doesn't feel restorative.
No wonder people feel exhausted. But it's not just about being tired, is it? This constant disruption, it's got to have other effects.
Right. There are a ton of other effects. So what are some of the things people should be looking out for, that might make you think, maybe this is OSAS?
Okay, so red flags. If you're experiencing 2 or more of these regularly, it's time to have a chat with your doctor. Big one, loud snoring. We're not talking gentle snores here. It's got to be disruptive, the kind that keeps your partner up.
Yeah.
And then, of course, if someone's actually seen you stop breathing during sleep, those are the witnessed apnoeas.
Those are scary.
They can be, yeah.
Yeah.
But even if you don't fully stop breathing, if you're always waking up feeling like you haven't slept, even after what should be enough hours, that's a sign.
Okay.
Waking up with headaches, especially first thing in the morning, that can be linked.
Makes sense.
And then there's the classic. Excessive daytime sleepiness. You're just constantly fighting to stay awake, even when you should be alert.
I think a lot of people are familiar with that one.
Yeah, for sure. It's the most obvious. But there are a bunch more, maybe a little less obvious, but still important.
So what else should we be aware of?
Waking up to pee a lot at night, that's called nocturia. That can be connected. Waking up gasping or choking for air, that's a big one.
Definitely.
And even if you don't remember waking up, if your sleep feels really broken up, like insomnia-ish, that could be OSAS too. And then things like trouble concentrating, memory issues, just feeling foggy.
Wow, that's a lot to consider. It's not just about feeling sleepy, is it?
Nope, not at all. It's way more complex. And here's another layer. OSAS doesn't just pop up randomly. There are certain health conditions that make it more likely. So if you have any of these, OSAS is definitely something to talk to your doctor about.
Okay, so what kind of conditions are we talking about here?
It's a pretty wide range, which is interesting in itself. Obesity or being overweight, that's a major one, and that includes during pregnancy.
Pregnancy.
Yeah. And then you have hypertension, specifically the kind that's hard to control with meds. Type 2 diabetes, some heart rhythm problems, especially atrial fibrillation. So if you're dealing with an irregular heartbeat, your sleep might be playing a role, and the other way around, too.
That's a connection I don't think a lot of people would make.
Yeah, it's not always obvious,
Yeah.
but it's there. And the list goes on. If you've had a stroke or a TIA, that's a transient ischemic attack.
Right.
Chronic heart failure, even moderate or severe asthma, all linked.
Okay.
And that's not all. Polycystic ovary syndrome, Down syndrome, and then there's this condition called non-arteritic anterior ischemic optic neuropathy.
Wow. Say that 3 times fast.
Try it. But seriously, it's a sudden vision loss in one eye because of reduced blood flow to the optic nerve. And it can be connected to OSIS.
That's incredible.
It is. And then, to round it out, hypothyroidism and acromegaly, which is a hormonal disorder, they're associated too. So you see, OSIS really touches so many areas of health. It's a reminder to think about it, even if your main concern seems totally unrelated.
Yeah, it really emphasizes how interconnected everything is. So if you're listening and some of this is ringing a bell, you're like, oh, wait, maybe this is me. What's the next step? What are some of the tools, maybe initial assessments that can help, get a clearer picture?
So there are a few things that can help. One of the most common, it's called the Epworth Sleepiness Scale. It's a questionnaire, basically. You rate how likely you are to doze off in different everyday situations. You might have even seen it before.
I think I have. And Anise mentions another tool, the Stop Bang questionnaire. What's that all about?
Ah, yes, the Stop Bang. Healthcare providers often use this, along with the Epworth, to get a broader picture of your risk. S.P, that stands for snoring, tiredness, observed apnoea, and pressure, like high blood pressure.
Right.
And then BANG, that's BMI, your body mass index. Age over 50 is a factor. Neck circumference, a large neck can be a sign. And then gender, being male, increases the risk. So it's looking at all these characteristics together.
Okay, so we have these questionnaires, but how do you actually use them? NICE seems pretty clear that you shouldn't just jump to conclusions based on one.
You're absolutely right. The guideline is very specific. Don't decide if someone needs to see a sleep specialist based only on their Epworth Sleepiness Scale score.
Right.
Because not everyone with OSIS feels super sleepy during the day. They might have other really bothersome symptoms like that unrefreshing sleep or the brain fog. And those shouldn't be ignored just because their Epworth score isn't that high.
Yeah, don't just brush it off because one number doesn't fit.
Exactly. It's about looking at the whole picture, all the symptoms, the risk factors, all of it together.
Makes sense. Now, there are some people where getting assessed quickly is extra important, right? Like it needs to be bumped up the priority list. Who are we talking about here?
So when we're talking about a sleep service, there are a few groups that should be seen more urgently if OSIS is suspected. People with jobs where staying alert is crucial for everyone's safety, like truck drivers, pilots, anyone in those kinds of roles.
Good sensitive, yeah.
Exactly. And anyone with unstable cardiovascular disease. We're talking things like poorly controlled heart rhythm problems, chest pain at night, really stubborn high blood pressure.
So anything that could put them at higher risk if OSIS is also present.
Exactly. And then pregnant women, because OSIS during pregnancy can have complications. People who are getting ready for major surgery, that's another group. You want to get any underlying OSIS under control before a big operation.
Of course, that makes sense.
And lastly, anyone experiencing that sudden vision loss we mentioned, the non-arteritic anterior ischemic optic neuropathy. Because again, it could be connected to OSIS.
Okay, so you get referred for assessment. What happens next? What kinds of tests should you expect?
So the first line of defense, what NICE recommends, is a home respiratory polygraphy. Basically, you wear sensors while you sleep, right in your own bed, and it tracks how you're breathing.
It's like a little sleep detective.
Kind of, yeah. Monitors your breathing patterns, your heart rate, your oxygen levels, all overnight. Gives us a good initial picture.
Okay. But what if home polygraphy just isn't an option? For whatever reason, what are the alternatives?
If that's the case, home oximetry might be considered.
Yeah.
It's simpler, just measures your blood oxygen levels and your heart rate while you sleep.
Okay.
But, and this is important, oximetry on its own isn't as good at telling OSIS apart from other things that can cause low oxygen, especially for people with heart failure or chronic lung diseases.
So it might be a starting point, but it's not the be-all and end-all.
Exactly.
So let's say those initial home tests come back negative, but the person is still having all these symptoms and it really seems like it could be OSIS. What happens then?
If that's the case, then further testing is usually the next step. Either another go with respiratory polygraphy or a more comprehensive sleep study called polysomnography.
Polyphonography, that's the one you do in a sleep lab, right?
That's the one.
So when would you do that instead of just another polygraphy?
Well, a few scenarios. If home testing just isn't practical, maybe someone can't manage the equipment or they need more detailed monitoring, then hospital-based respiratory polygraphy is an option. And if that initial home polygraphy comes back negative, but we still strongly suspect OSAS because the symptoms are so persistent, then it's time for the full polysomnography. It gives a much more detailed view because it's not just breathing, and brain waves, muscle activity, the whole shebang.
So it's like getting a high-definition picture of your sleep.
Exactly, exactly.
And what are the doctors looking for in those reports? What do those results actually tell them?
Well, the results, especially a measure called the apnoea hypopnoea index, the AHI, that's key.
AHI, right.
It basically counts how many times you completely stop breathing, the apnoas, and how many times your breathing significantly drops, the hypopnoas, per hour of sleep.
Okay.
And based on that number, we can say, okay, this is mild OSAS, moderate, or severe.
So it's both confirming the diagnosis and figuring out how bad it is.
You got it.
Okay. Diagnosis, that's step one. But then there's treatment. And it sounds like lifestyle changes are a big deal no matter what, how mild or severe the OSAS is.
Yeah, big time. NICIS really hammers this home. Talking about lifestyle changes is a fundamental part of managing OSAS, whether it's mild, moderate, or severe.
So what are we talking about here? What kinds of changes?
Well, things like losing weight if you need to, quitting smoking, cutting back on alcohol, and working on those sleep habits, good sleep hygiene. And the guideline even points you to other NICE guidelines that go into more detail about each of these.
So it's like a whole package deal.
Exactly. It's not just about treating the symptoms. It's about making those healthy changes that can actually impact the root cause.
Makes total sense. Okay, so let's talk specifics. Starting with mild OSAS, what are the recommendations there?
All right, so for someone with mild OSAS, who either doesn't really notice any symptoms or their symptoms aren't messing with their daily life, the guideline says active treatment might not be needed right away.
Interesting.
But, and this is crucial, those lifestyle changes, those sleep habit improvements, those are still super important. It's about stopping things from getting worse.
Preventing it from escalating, basically.
Yeah, exactly. But what if someone with mild OSAS is really feeling the effects, like it's impacting their quality of life? What then?
That's a good question. What do you do then?
In that case, the first line of treatment is often CPAP, continuous positive airway pressure. You wear a mask over your nose or mouth while you sleep, and a machine delivers a steady stream of air at a certain pressure to keep your airway open.
CPAP. That's pretty standard for sleep apnea, right?
Yeah, it is. And it's usually recommended along with that lifestyle advice, especially if they also have any of those priority factors we talked about, or if lifestyle changes alone just haven't done the trick.
Right. NICE also mentions telemonitoring with CPAP. What's the point of that? Why monitor remotely?
It's pretty cool, actually. Telemonitoring lets healthcare pros keep tabs on how you're using your CPAP and if it's working well, all remotely. So the guidelines suggest offering this for up to 12 months and sometimes even longer.
Okay.
It's helpful because it can catch problems early on, like if the mask is leaking or the pressure isn't quite right. And you can adjust things without needing to go to appointments all the time.
So it's like having a virtual checkup for your CPAP.
Pretty much, yeah.
Okay. Now, what about auto CPAP? Is that something that's used for mild OSAS?
It is, yeah.
Yeah.
But it's usually an alternative to the fixed-level CPAP, and only in certain situations.
So what kind of situations?
Well, if you only need that higher pressure sometimes during the night, or if getting used to a constant pressure is tough, auto CPAP might be better. It automatically adjusts the pressure throughout the night, so it's personalized.
That sounds pretty high-tech.
It is, yeah. It's also considered if telemonitoring just isn't possible, for technical reasons, or if auto CPAP ends up being cheaper than the fixed-level CPAP over time.
Okay, cost effectiveness, that's a factor too.
Always.
Now, we all know CPAP can have some downsides. Some people get a dry nose or mouth from it. Does NICE talk about how to deal with that?
They do, yeah. If you're using CPAP for mild OSAS and you're getting those upper airway side effects, the dryness, the CPAP-induced rhinitis, the guideline says think about adding heated humidification.
Humidification, okay.
Yeah, it often helps with those discomforts. And of course, huge reminder here, CPAP, it's an aerosol-generating procedure. So infection control, especially with things like, COVID's still around, that's got to be top of mind.
Absolutely, can't forget about that. Now, what if someone with mild OSAS just can't stand CPAP or they flat out don't want to try it? Are there other options?
There are. So for adults 18 and over, if their teeth and gums are in good shape, the guideline suggests a mandibular advancement splint.
Mandibular advancement splint, that sounds like a mouthful. What is that?
It is a bit of a mouthful, but it's basically a device you wear in your mouth while you sleep. Think of it like a custom-made mouth guard. It pushes your lower jaw forward just a bit,
Okay.
and that helps keep your airway open.
So it's like repositioning your jaw to prevent that airway collapse.
Exactly.
Are there any times when that wouldn't be a good idea, though?
Yeah, there are. If you have active gum disease, untreated cavities,
Yeah.
if you have very few teeth or no teeth at all,
Okay.
or if you have generalized tonic-clonic seizures.
Okay, so there are definitely some situations where it's not the right fit.
Right.
All right, that's mild OSAS. What about moderate or severe OSAS? Is the treatment approach pretty similar?
It's similar in some ways. Fixed-level CPAP, that's still the go-to, along with the lifestyle advice
Okay.
and all those considerations about telemonitoring, when to use auto CPAP, humidification for side effects, all that still applies.
Yeah.
And of course, infection control is always crucial, always.
Always, yeah. Now, what about the mandibular advancement splints for moderate or severe OSAS? Are those still on the table if CPAP doesn't work out?
They are, yep. If someone can't tolerate CPAP or chooses not to use it, those custom-made splints are a possibility.
Okay,
But again, you got to be 18 or older and have good dental health. Same rules apply.
got it. So it sounds like CPAP and these mandibular splints are the main treatments. Are there any other options that NICE mentions for OSAS?
There are a couple more. For people with mild or moderate positional OSAS,
Positional.
yeah, meaning their AHI is way higher when they sleep on their back.
Ah, okay.
So for them, we might consider positional modifiers, but only if other treatments aren't working or they can't handle them. These modifiers are basically things that help you stay sleeping on your side.
So like a special pillow or something?
Could be, yeah. Or even a tennis ball sewn into the back of your pajamas. It's about preventing you from rolling onto your back.
I've heard of that one, but this wouldn't work for severe OSAS, right?
Probably not, no. It's more for milder cases where the position really makes a difference.
Okay. And what about surgery? Is that ever an option for OSAS?
Sometimes, yeah. If someone has really large tonsils that are clearly blocking things and their BMI is under 35, a tonsillectomy might be considered.
Okay.
And for severe OSAS, if both CPAP and a custom-made splint have been tried under medical supervision and they just haven't helped, then we might think about referring them for an assessment for oropharyngeal surgery. That's kind of a last resort.
Got it. Now, OSA is often linked with, well, stuffy noses, runny noses, all that. How does NICE say to manage rhinitis in people with OSAs?
First things first, you got to figure out what kind of rhinitis it is. Is it allergic? Is it vasomotor? Once you know that, the initial treatment's usually topical nasal corticosteroids, or maybe antihistamines if it's allergic rhinitis.
Okay.
But if the rhinitis is stubborn, doesn't go away, or if we think there might be something physically blocking the nose, then it's time to bring in an ENT specialist.
Makes sense. So taking care of the nose issues is a pretty big part of managing OSAS effectively.
Oh, definitely. The guideline even points out that rhinitis can really affect how well someone can tolerate CPAP. Sometimes switching to a full face mask instead of just a nasal mask and adding humidification, that can make a difference.
Interesting.
But here's the kicker. CPAP itself can actually make rhinitis worse, or even cause it in some people. It's kind of catch-22.
Wow, that's tricky. Okay, so let's say someone's diagnosed, they start treatment. What happens next? What's the follow-up like?
Well, the follow-up should really be personalized, right? It depends on their treatment plan, what lifestyle changes they're making, any other health issues they have. But for people using CPAP, NICE recommends an initial checkup within a month of starting, and then more appointments as needed until their symptoms and their AHI or ODI are under control. Once things are stable, an annual checkup is usually enough, but they should always have access to the sleep service if they have questions or need help.
Okay, so regular check-ins, but with flexibility based on the individual.
Exactly. What about people using those mandibular splints or positional modifiers? Is the follow-up different for them?
Yeah, is it?
It is, a little bit. For the splints, the first follow-up is usually around 3 months after starting to see how well it fits and if their symptoms are improving.
Okay.
And then you go from there, more appointments as needed. Same idea with the positional modifiers. First checkup within about 3 months, then adjusted based on how they're doing.
Makes sense.
Now, if someone's had surgery for OSAS, their first follow-up, that usually involves a respiratory polygraphy and happens within 3 months of the surgery.
Okay.
And then, again, more appointments as needed.
And I imagine for drivers, especially those who've had issues with excessive sleepiness, following the DVLA guidelines is crucial.
Absolutely crucial. Safety first, always.
Always. So regular monitoring is key. What are the doctors actually looking at during these follow-ups? What are they checking?
Lots of things. First, they'll check in about your symptoms, see how you're feeling, how sleepy you are, how alert you are, especially if you're driving.
Right.
They'll also reassess the severity of your OSAS, probably using the AHI or ODI from a sleep study.
Okay.
And they'll want to know how well you're sticking with your treatment, how often you're using your CPAP or splend. And they'll look at any data from your device, like telemonitoring info.
So they're getting a really complete picture of how things are going.
Yeah, and for CPAP users specifically, they'll also want to know about your experience with it. How's the mask fitting? Any dryness? Or other things affecting your sleep? How's your sleep hygiene? Are you cleaning your equipment properly? The whole 9 yards.
Wow, pretty thorough. Now, I read that NICE even mentions stopping treatment in some cases. Is that right?
Yeah, that's right. If there's a good reason to think the OSAS might be gone, for example, if someone's lost a significant amount of weight and kept it off, then stopping treatment might be considered.
Okay.
But even then, we'd want to wait at least 2 weeks without treatment and then see if any of those old OSAS symptoms come back. A repeat sleep study might be needed too, just to be sure.
So it's not a decision to be taken lightly. You want to make sure it's truly resolved before stopping any treatment.
Absolutely.
We've talked a lot about different treatments, but we all know that sticking with treatment, especially long-term, can be really tough. What does NICE recommend for helping people, keep up with their OSAS therapy?
This is so important. The guidelines strongly recommends offering support, either educational or just general support, to anyone starting treatment for OSAS, whether it's CPAP, the splints, or positional therapy.
Okay.
And it's not just at the beginning, it's ongoing, as needed during follow-up. And it should be done by people who really know their stuff, specialists in this area.
Right, so not just a pamphlet, but real personalized support.
Exactly. And it should be tailored to what the person needs and what works best for them.
Makes sense. Okay, so that was a deep dive into OSOS. Let's move on to the next one. Obesity hypoventilation syndrome, OHS. What exactly is it and how is it different from OSAS?
All right, OHS, it's a bit more complex. It's diagnosed when someone has a few specific things going on. One, obesity, so a BMI of 30 or higher.
Okay.
Two, high carbon dioxide levels in their blood while they're awake. We measure this with a blood test, an arterialized capillary blood gas test.
Okay, so that's a blood test, but not just any blood test.
Right. And three, they have to have breathing abnormalities during sleep. That could be the obstructive apneas and hypopnoas like in OSAS, but it can also include periods of hypoventilation.
Hypoventilation, okay.
Yeah, that's when their breathing is too shallow to get rid of enough carbon dioxide.
So their body's not getting rid of the waste product properly.
Exactly. And it's important to understand that OHS, it's actually a form of chronic ventilatory failure.
Wow, okay. So if someone has a BMI of 30 or higher, what would make them or their doctor think it might be OHS and not just OSAS?
Well, if someone with that BMI also has the classic OHS features, the snoring, witnessed apnoeas, not feeling rested, all that, OHS should definitely be on the radar.
Okay.
But there are some signs that are more specific to OHS, particularly those linked to nocturnal hypoventilation.
Like what?
Waking up a lot with headaches, swelling in the legs or ankles, we call that peripheral edema.
Right.
Low blood oxygen levels, that's hypoxemia, and an unexplained high red blood cell count, polycythemia.
Okay, so those are more unique to OHS.
You tend to be, yeah.
Now, it seems like the Epworth Sleepiness Scale pops up again for OHS.
It does, yep. It's part of that initial sleepiness assessment.
But again, it's not the only factor, right?
Right, just like with OC, you can't just go by the Epworth score alone. Not everyone with OHS feels excessively sleepy.
Okay, so we're looking at the bigger picture. Are there also specific groups with suspected OHS who should be seen more urgently?
Definitely. If someone's suspected of having OHS, rapid assessment is key if they have severe hypercapnia. That means their carbon dioxide level is over 7.0 kPa when they're awake.
Okay.
Or if they have hypoxemia, meaning their blood oxygen level is below 94% when they're awake.
Okay, so those are the urgent ones.
Yep. And then anyone experiencing acute ventilatory failure, that's an emergency. And then the other groups are similar to OSAS. Drivers, people in safety critical jobs, pregnant women, people with unstable heart conditions, anyone pre-op for major surgery,
Right.
and those with that vision loss condition.
Right.
So basically anyone where the risks of untreated OHS are really high.
Got it. So If OHS is suspected, what tests are done to figure it out for sure? What's that process like?
Well, there are a few key steps. To officially diagnose OHS and figure out if there's chronic ventilatory failure, we need to measure those blood gas levels, the oxygen and carbon dioxide, while the person's awake.
Okay.
That's the arterialized capillary blood gas test.
Right, that one.
Sometimes, if we're not really suspecting OHS strongly at first, we might do a serum venous bicarbonate test as a first step.
Okay.
If that bicarbonate level is low, makes OHS less likely.
Right.
But super important point. If someone's in acute ventilatory failure, we're not waiting around for more tests. They need treatment right away.
Of course, that's an emergency. So once you're looking at the possibility of OHS, what sleep studies are done to see if there's OSS present too, or if there's that nocturnal hypoventilation?
For that, we'd offer respiratory polygraphy either at home or in the hospital.
Okay.
And we might add something called transcutaneous CO2 monitoring.